Is oxycodone an evil drug? Is oxycodone, like heroin, should be banned? No, I don't think so. I think we just need to figure out we're doing very good in the reduction of opioid prescribing, where we've made headway, we've seen the data. What we still have a problem is figuring out who should be on opioids and who shouldn't be on opioids, and assessing the patient. That requires time and effort, and a lot of doctors don't have that, unfortunately, or aren't willing to do that. So chronic pain, if you remember when this came out, Institute of Medicine in 2011, it was a big 600 and something page report, whatever, from the federal government, said chronic pain is a problem, and this is the breakdown, and this is the cost. They actually said it was about 630 billion. I think Chris changed his slide because there was some controversy about that. At ACIP had written some editorials to say it really is more like 100 billion. Well, that's not pocket change. It's still a lot of money, $100 billion. It's between 100 and 600 billion. This is the prevalence. You'll see that this elderly is an issue. I mean, I have a mother-in-law up in New York who's 90, and I can tell you, I just don't think elderly get treated well. I mean, I'm a physician, and I talk to the doctor, and they just, you're old, you know, and, oh, you're gonna have pain, you're old. Well, not saying that's a good thing. So I'm not sure what he meant by this picture, by the way, but I have been to China, and I can tell you that, I was thinking about this. Everybody has a job in China, if you ever go there. If you go to like a department store, there's like 8 people in the men's department, very often women. There's a ton of people working because everybody's got to have a job in China. Because if they don't have a job, there's civic unrest, whatever. So everybody's got to have a job in China. This might not be the best one, but. Okay, I think we just alluded to this. So these are the numbers based on varying studies. So this is an interesting thing. So how many of you have ever heard this? It's rare to have addiction in patients treated with narcotics for pain. Isn't it rare? Where do you remember hearing that? Anybody remember? Well, that's one place. Okay, where else? I'm going to show you where. Okay, so we were told, I remember this from the early 2000s, that addiction is rare in pain patients and chronic pain protects you against addiction. It's like a force field. Okay, that's true in animal studies. You can do an animal study and you can induce chronic pain in a rat, like the little rat was pressing that. You can inject formalin in the paw. They have chronic pain models for animals. And they will not self-administer like they did before. So they said, chronic pain protects against addiction. Not so in human beings. So where did this come from? So it's been cited, this statement has been cited in over 1,000 articles. New England Journal of Medicine talked about it, but where did it come from? It came from this, and this isn't even a study. And I remember this because I remember giving a pharmaceutical talk in the early 2000s for an opioid company, and they had a slide that quoted this. And I didn't know it wasn't a study. This was a letter to the editor, to the New England Journal of Medicine. It's called the Porter letter to the editor, and it's a Boston collaborative study. And they did a study, but they didn't publish it. They wrote their findings. What'd they say? Out of almost 12,000 patients, only 4 cases of addiction. And in only one instance, and I remember the breakdown, they looked at outpatient chronic pain. They even looked at burn patients in the hospital. How many of you have worked at a burn unit in your past lives? Okay, I don't know how you measure addiction because everybody's on a morphine drip. They're all hypermetabolic. I just don't see how you can even, if somebody was addicted, it wouldn't even matter. They'd be on such high morphine doses anyway because they're in horrible pain. I don't see how you can measure that, but from this, the conclusion is you just don't see addiction in pain patients. And that's what they base this on. That's what pharmaceutical companies based it on. That's what the all pain societies and even CMS. You pick up with something and you run, and look what it's based in, not a whole lot. Okay? Pseudo-addiction, how many of you have heard of that? Pseudo-addiction. Okay, so you've heard of, we talked about misuse, abuse, and substance use disorder. Those are all, I think abuse and substance use disorder are listed in the Diagnostic Statistical Manual, the DSM-5. These are codified in our literature. We have allodynia, hyperalgesia, hypoalgesia. These are defined terms. Okay, pseudo-addiction has become defined. Do you know how it became defined? Oh, everybody knows what this is, I'm sorry, I assume. Addiction behavior that develops as a direct consequence of inadequate pain management. You don't treat the pain right, so they go running around to all sorts of places demanding pain management, usually opioids. Pseudo-addiction, because once you get a hold of them and manage them, they stop doing it. That's the theory, okay? This is where it came from. A clinical note, not a study. This is by Haddix and Weissman. David Haddix used to be the medical director of Purdue Pharma. This was a case presentation. One case. Okay? And that one case became a syndrome and in our lexicon. Okay? I'm guilty of this too. I have slides that show pseudo-addiction stuff. A major effort is needed to educate professionals regarding appropriate use of opioid analgesics and true facts regarding opioid tolerance, physical and psychological dependence. The recognition of pseudo-addiction as a true iatrogenic syndrome with a definable cause, natural history, and effective treatment will hopefully improve the way in which patients receive analgesic. One case report. Okay. And that led to this. Okay. You've seen some of these as well, manslaughter cases, etc. So how many of you are familiar with the JACO rating that came out in the early 2000s that pain is the fifth vital sign? Oh, everybody was thrilled about that, right? So what happens as a consequence of that? Well, in this study, and it was authored by one of our board members, the late Raphael Miguel, was a co-author, that it seems that when you start to institute this and implement it in a hospital, that patients get more drugs because they're in pain. I'm in pain, I'm in pain. What's the easiest way to medicate somebody in the hospital? Opioids, okay, especially for acute pain. And what happens is, I don't know if you can read this, sedation adverse drug reactions per 100,000 increased from 11 to 24.5 with a statistical difference of 0.001. So although improvement in patient satisfaction, we experienced a more than twofold increase in the incidence of opioid over sedation and adverse drug reactions. Big surprise, right? Okay. I'm not sure why he has that in there. So maybe because he's referring to pain facies, I don't know. So there's different types of pain, and I'm in pain, doctor. I always, when I have a new patient come to the office, I said, what brings you to the office? I do this every single time. I never change. I never say, tell me about your leg pain, because they're shading in the room. I say, what brings you to the office? I want to see what they say. 99.9% of the time, what do you think they say? I'm in pain. I said, and so then we go back to square one. Okay, what kind of pain, etc. Once in a while, someone will say, my back and my right leg hurts because they told me I have a herniated disc. Well, that's nice to get that, but you don't get that. Most of the time, I'm in pain. What kind of pain? I'm in pain. Patients don't know neuropathic pain and visceral pain. They just know it hurts, okay? Self-report is the most reliable or unreliable measure of pain. Certainly the numeric pain score, I still use it, but it needs to be used in conjunction with other things. There are Beck depression inventories and other ways of measuring discomfort. There's the FACES scale, which is probably, we've instituted that too in our practice. I actually have it in a little thing. Because patients who will tell you, I have a 10, I have a 15, it's a 20, it's a 20, it's a 15, I say, stop right now. The worst it can be is a 10. I'm telling you it's a 15, doc. Okay, enough. Show me where you are on the face. Really. And sometimes it's even less than the worst face, because they can see it now. It's a little more quantifiable for them. Again, you don't want to treat the number. So different types of pain. Nociceptive is tissue damage, surgical pain, rheumatoid arthritis, osteoarthritis, gout. Neuropathic pain, poster child is postherpetic neuralgia, right? Peripheral neuropathy. Psychological or sensory, unidentified tissue damage resulting from psychological comorbidity or neuronal dysregulation. There might be another category called central pain here too, which usually manifests with neuropathic syndromes like post-stroke syndrome, okay, or thalamic syndrome. Fibromyalgia too is a centralized, is a hypersensitization of central pain syndrome. So we like to practice in here, right, the intersection of all three of these. And this is basically a Venn diagram showing you the intersection of, and the treatments, or the intersection of all these pains. So there's a study I remember from, I can't remember where I saw it, that something about like 90% of back pain that's reported, I have low back pain, a significant component, like over 45% is neuropathic, that there's a neuropathic element to it. We like to classify back pain as radiculopathic, axial, et cetera, but it can be a mixture, especially involving the disc, right? Okay, so you've seen the World Health Organization, et cetera. What do you choose and when should you choose it? And are these things benign? Nociceptive pain is quite sensitive to opioids. I had a hip replacement, I can tell you. Actually, that wasn't too bad. But I had a hip, the year before I had a labral repair, and that was painful. Knee surgery is pretty painful. It tends to be pretty responsive to opioids, not terribly to anti-inflammatories. And for postoperative care, it's appropriate. Visceral pain, opioids, anti-inflammatories, maybe even a modulator like gabapentin. Muscle spasm, cervicalgias, cervical dystonias. You've got spasm of the muscle, release the muscle, either with a medication or with botulism toxin. Neural compression, opioids and steroids, probably less opioids, steroids are better. Neural injury, now you have the modulators, the antidepressants, and the anticonvulsants. But what works, the most sensitive, opioid sensitive is nociceptive, and the least is probably neuropathic. So if you're going to use an opioid, you have to consider short-acting, long-acting. If it's acute, certainly short-acting. And the Cmax-Tmax ratio, or the abuse potential, not a well-defined, it's really defined by, in the pharmacist or pharmacology world. So a drug that has highest abuse potential has a very low Tmax, so it gets to its peak very quickly and has a very high peak. So a drug like fentanyl has a high abuse potential, high Cmax over Tmax. A drug like morphine is less. An extended release version has even less. Okay. So you kind of all know this. You have different spots in the nervous system where different drugs act. Central sensitization, NMDA receptor antagonists, local anesthetics, neuromodulation is in here somewhere, et cetera. So rational polypharmacy is the goal. When we talk about, well, this is polypharmacy, the pharmacist will say this is polypharmacy, maybe in a critique of you using too many drugs. You might say it's rational polypharmacy because this drug works this way, this drug works on this mechanism, and this drug works independently, and they're mutually exclusive, and they give me a picture of adequate pain control. Non-pharmacologic management, you kind of know all this. Psychotherapy or psychological treatment is not easy to get in managed care, and certainly these aren't paid for a lot. And their usefulness has been, some people swear by them, others don't. So what's left for you, antidepressants, anticonvulsants, non-steroidals, we'll talk about them in a minute. Capsaicins, they're hallmarks in the treatment for non-opioid pain. Okay, interventional pain, getting harder and harder to get that approved, but it works. You have to balance these, obviously. So these, I'm going to show you the next few slides, show even with without heart disease, nonsteroidals can pose a significant threat. This is one of impact on risk of death with recurrent MI in patients with prior MI. Okay, even short-term use with most NSAIDs, some are worse than others. You know that Vioxx was significantly worse, but even I think it's naproxen is worse than ibuprofen. I never remember. And celecoxib was studied out to about a year, but it never got studied after that. Again, significant risk. And what's the FDA doing about this? They put some warnings in, but are we curbing the use of these medicines? I will tell you, I cannot take non-steroidal anti-inflammatories. If I take them, my stomach is gone. I can take one non-steroidal, I can take celecoxib, and that's what I use if I have to. That's the only one that I can tolerate. And that goes the same for aspirin. I can tolerate baby aspirin, but not regular aspirin. Again, this one was the FDA warnings about NSAIDs causing heart attacks or strokes. You heard about these in 2015. It doesn't seem to be making a bit of difference epidemiologically that I can tell. It can increase the risk of an MI or stroke patients with or without heart disease. Wow. So certainly if you have a hypertensive patient who's had a prior MI, you really need to probably not use these meds. But what about if they don't have that, or they have a little hypertension? And they say, I can function really well on Voltaren, oral diclofenac. I take one or two a day, and I'm like, great, I don't want opioids, doc. Is that good? Yeah, it's good for the opioid part, but maybe it's not good for them long term. Okay. So many of these patients, like especially these folks, they already have chronic renal, at least diminished renal function if they're elderly. They probably have some form of heart disease. So they're already, a lot of rheumatologists I've seen, maybe not in the elderly, but in a younger patient, will use things like Indocin. Indocin is very powerful. Has anybody ever taken Indocin? Indomethacin? I took it once. My ortho wanted me to take it post-operatively of my first hip replacement to reduce inflammatory changes, and he had to do a graft in there too. And I said, I don't know if I can tolerate this, and I was taking a PPI with it for 3 days. But I did take indomethacin once for a neck injury. I was hit when I was on my bicycle, and I had a lot of neck and shoulder pain. That stuff works. It's amazing. But what does it do to your stomach, kidneys, and heart? And in cancer, if you take your board exams, opioids are the primary go-to drugs in cancer pain. They're not quaternary or tertiary like they are for us in non-cancer pain. There have been some studies with opioids that show good results. There's not a lot of them. There's some efficacy in multiple randomized control studies, 3 to 6 months, even as high as 180 morphine equivalents, okay? And long-term efficacy, you get up to about 12 months, comparable. So there are some studies, but they're not, level 1 evidence, okay? And you'll hear a lot of anti-opioid pundits say opioids don't work. The literature shows they don't work. That's simply false. There's just not enough evidence to their satisfaction to make them work, okay? I'm not anti-opioid or pro-opioid. I like to say I'm pro-patient. I'm neither. We talked about some of these. The ACIP, American Pain Society, created guidelines before the CDC did theirs. And based on those studies that I showed you. You know all this. The guidelines, and particularly in the CDC, will make all these recommendations. Drug testing, when appropriate. I think CDC recommends at least once a year. There is no law in Florida about urine drug testing. It vaguely recommends some diagnostic testing, but it does not say you must do urine drug testing, blah, blah, blah. Okay. Okay, and using safe and effective methods for discontinuing tapering, that's not always that easy to do. But everybody agrees, including the folks in Florida, you must access the PDMP. It's law now, so. Okay, does the molecule matter? You know, if you're not versed in opioids or you're a layman, you might say, well, they're all painkillers, what's the difference? But we know there's a difference, don't we? We've seen it, right? And some of the differences may be due to the molecule, they might be due to the patient who has a different enzymatic system, maybe 2D6 deficient or not deficient or hyper 2D6. Some of these are metabolized by the CP450 system, some aren't. Okay, but they do have very different, some of them have stimulatory properties. In my opinion, there's a big stimulatory property between this and morphine's not even listed here. Oh yeah, there it is, morphine. They're just different. Patients react to them differently. They just feel different, so. Does the molecule matter? I just basically said all this, so. Okay, you might have to switch opioids, opioid rotation. I've been taking this medicine so long, I have to increase the dose. It doesn't work anymore. Opioid rotation is a valid tool, okay? Different opioids act differently. Be careful when you do this with methadone, though. Be very careful, okay? Again, NSAIDs, there's really long-term use. You're just going to buy problems with them. And they're the leading cause of cardiovascular, GI, and renal disease. That's the kind of numbers we're looking at. Drug-to-drug interactions, tramadol, methadone, P450. I think they just came out with I think I just read that there's a new product, the methyl tramadol is now being marketed, or there was a study that just came out. So tramadol is metabolized to N-methyltramadol or desmethyltramadol. That's the active metabolite. I think somebody's going to be making this now. And it's 56 times more potent than tramadol. So you don't have to worry about P450 issues. Opioids work. I mean, they've been used for thousands of years. Morphine works. They are profound analgesics. Are they for everybody? No. Where do they work the best? Probably in acute circumstances. Okay, but not always, and everybody's different. Okay, and you've got to remember this. If somebody is going for surgery, major surgery, and they have PTSD and they have ADHD, they have these comorbid events, the surgeon is going to probably not care about that. But you need to care, especially if they're your patient, because it could trigger something. I can't tell you how many times I've had patients who are alcoholic. They've been in AA for 25 years. They go in for surgery, and they get Percocet, and bang, that's it for them. Because nobody really thought about it. Nobody took the time to, and you don't want to, you can't withhold the medicine. Well, you're an alcoholic. We're going to give you Motrin. No, but they need to say, the surgeon needs to say, you need to talk to me if this affects you anyway. You need to let me know. Okay. It makes sense if any drug you use, you're going to want to use the lowest possible dose. I mean, it doesn't matter what it is. And opioids are no different. And this is Chris's recommendations. You have certain states that take this away from you that say, these are the morphine equivalents that you must do. Most of the states, to my knowledge, have used 120. I think there are some that are really pushing. State of Washington, there's some players behind this that are pushing to get this down to like 50. There's only one drug on this list that actually has it in the product information, that it is actually an FDA labeling. Tapentadol has a maximum dose of 450 milligrams a day. You've seen this before. Worthwhile discussing here, I had a slide, I didn't put it in, I should have, that the US has had multiple opioid epidemics. We have one now, and it started in, I don't know, the late 90s. And we had one in the early 20th century. especially after World War I. And paralleling opioids in both epidemics are stimulants, cocaine and methamphetamine. They both, more cocaine in the early 20th century, now methamphetamine, that parallels opioids. It always does, and it's happening in the United States. Cocaine and methamphetamine are on the rise. OIH, something you need to be aware of. When patients continue to elevate their dose and they say, I still hurt, or I'm hurting more, or I'm more sensitive and it's not working, it's not just tolerance, it could be OIH. There's a whole lecture on this. I won't get into the details of why it happens, but it does happen. Again, reducing misuse and abuse. You have abuse deterrent formulations that are on the market that are virtually not covered by any insurer, as far as I can tell. Yet they're still being manufactured. You're going to hear about this Saturday morning, by the way, if you come to the breakfast. But I think it's a tool, and it's a useful tool. It's just a public health issue that the government hasn't figured out how to do yet. Again, all these things, we've talked about it. You have to do this. You're in drug testing, you don't have to, but community standards will tell you that you do. Treatment agreements you have to do. Risk assessment tools, easy to do. Patient education takes a lot of time to do this, a lot of time. Have an exit strategy. You have somebody that you started on opioids and they've now a problem. The answer is not to discharge them and send them somewhere else. The answer is to take responsibility. If you inherit someone like this and you need help, get help. You might say to this patient, listen, I want to treat you, but I really don't have the tools to do it. Go see Dr. Silverman, go see someone else, and come back to me. I will work with you, but I can't do, this is outside of my sandbox. Don't be afraid to say that. That's why I think everybody should have their X number, because it's an easy thing to get and it's an easy thing to do. And you use it for your own patients. Okay. Sleep apnea can be caused, central sleep apnea, by methadone and other opioids, or they can have it because of their body habitus, et cetera. Again, have a plan to face violations in your treatment agreement. Violations, urine drug tests that are abnormal. Have a plan. Okay. Acute illness, big deal. This is serious. You got to tell especially your elderly patients, if you get sick, you have pneumonia or the flu, you got to call the office and let us know. We don't want you to continue your extended release morphine in that dose. It could kill you. They become hypovolemic, hypotensive, and they pass out and they die. Multifaceted approach. Maybe we should write that spot down. The rest of these are take-home message, the last slide. Evidence-based and mechanism-based. Opioid molecule does matter. So does the patient. The patient really matters as well. You want to use non-opioids. The law says you have to do that. You know, the latest is now you have to put that pamphlet in your office, the non-opioid pamphlet. It's not a bad idea. I'm glad I didn't have to pay for it or create the pamphlet. I'm glad the DOH did. But once again, not a bad idea. And you might have somebody who's on opioids alone. If you can document it, well, we tried this, this, and this, and there were adverse effects. Patient is stable on this. But if you're just going to use it unilaterally and say, we're just going to put you on opioids, like many primary care physicians, I don't mean to insult primaries, but those physicians who don't have good training in pain management will resort to what they know, which are short-acting opioids for the most part. Don't overprescribe. Keep the pill count down. That may be out of your hands by insurance companies. And watch that methadone and the steady state time. Really be careful of that. And that's it.